Okay, thank you for introducing me, and thanks for giving me the chance to introduce conservative treatment of the uterus RF myolysis. My presentation in the following order, and let me begin with what RF myolysis is. High-frequency alternating current from the tip of the electrode causes movement of the ions in the contacted tissue, creating frictional heat in the process. Conducted heat that is generated around the electrode tip spread to surrounding tissues. This results in a subsequent therapeutic histological change like coagulative necrosis and vascular thrombosis in the feeding vessels, and inactivation of the ER and PR receptor to prevent regrowth of the tumor tissue. Heat fixation is a situation that, as a result of heat, the internal structure like cytoplasm is destroyed while the membrane of the cell is maintained. Weak thermal ablation provokes heat fixation, making thermal cell regeneration impossible. Cytoplasmic bleeding occurs and split into apoptotic bodies. Macrophages phagocytosis is it and remove them. We call this apoptosis. Strong thermal ablation provokes severe injuries in the cell, which directly destroys the cell. The integrity of the cell membrane is damaged and leakage of the cellular material occurs. Leakage material invokes an inflammatory cell causing inflammation. We call this necrosis. Thermal dose is directly proportional to the increased temperature within the tissue and the exposure time at which the increased temperature works. When the temperature rises above 65 degrees, the cells start denaturing and heat fixation occur. Then the exposure time increases, resulting in thermal necrosis. Treatment effectiveness and risk of complications are proportional to the thermal dose. Therefore, it is very important to use as much thermal dose as possible to achieve a good therapeutic effect while ensuring safety. Throughout the treatment plan should be continuously adjusted, monitoring the amount of joules used along with the treatment response of the lesion. As the heat generated around the electrode tip is conducted and spread to the surroundings, the amount of heat reached varies depending on the ablation area. A larger amount of heat reaches the nearby area, while only a small amount of heat reaches the far area. Suppose you see a hyperacute change on the ultrasound by ablating one spot. So the core has coagulative necrosis because of an adequate thermal dose, whereas the surrounding area has apoptosis caused by heat fixation due to a small amount of thermal dose. However, the damage to these two areas is irreversible, so you can think both of them as complete ablated. Although the heat is delivered outside of this area, it only creates reversible damage due to a small amount of thermal dose. If you look at the pathological finding after RF myolysis, complete coagulative necrosis can be seen in the central segment, but as you go to the marginal segment, the coagulative necrosis becomes incomplete. Also, the ER and PR receptor is either completely lost in the central segment or very much reduced. But as you go to the marginal segment, you can see the reduction is decreasing. The histologic change caused by ablation becomes weaker toward the periphery from the center where the electrode tip is inserted. not all areas of the hyperquick change on ultrasound are ablated. This is a contrast enhanced CT image taken by the first week of RF myolysis. As I explained before, the coagulating necrosis is clearly visible in the central area because there are multiple overlapping ablation is performed in the central area. But there are not enough overlapping ablation is performed in the neighboring area. Irreversible damage due to a heat fixation and reversible damage are mixed. Therefore, multiple overlapping ablation is needed for complete ablation of whole lesion. Even if the electrode tip passes through the uterus, there will be no bowel injury if the electrode tip is pulled back without any ablation. However, for safety, it is better to remove the needle completely and reinsert it again. If you ablate immediately after pulling the needle back, the heat can spread out of the uterus through the passage that was opened. Next, I will explain the RF myolysis procedure. There are 3 approach modes in RF myolysis. The first is the transvaginal approach. Because the electrode tip is secured to the needle guide, the tip does not deviate from the ultrasonic field of view while moving forward. But the uterus cannot be fixed because the electrode advances the uterus without counter-traction. And possibility of bladder or bowel injury is existed. The second is the transabdominal approach. You can check the field directly with your eyes, but the main benefit of RF myolysis, known as non-invasive treatment, is sacrificed because a trocar must be placed to insert the camera. And because of the CO2 gas, it is not possible to accurately monitor in a real time with ultrasound where the electrode tip is located and how much ablation has been made. The last one is the transcervical approach that I'm using. It is the safest way since the electrode tip enters through the endometrium. Counter-traction is possible with the tenaculum. Transabdominal ultrasound is used to check the electrode tip from the movement it passes through the cervix. There was an issue with spending a lot of time accurately positioning the tip in the targeted area, as the existing approaches required penetrating the firm uterus with a non-rigid electrode tip. The use of a coaxial needle can solve these problems. This is coaxial needle. The coaxial needle is composed of a cannula and stylet. A coaxial needle, as shown in the first picture, is inserted into the targeted area with the cannula and stylet combined in. After it is located in the target area, remove the stylet and only the cannula is remain in the targeted area. Insert the electrode tip through the cannula and then remove the cannula. Finally, there is only an electrode remaining in the targeted area. This is serial number of coaxial needle which I use. Next, let me talk about the treatment plan. As shadowing occurs in the real part where hyperquick change occurs, the visibility cannot be secured. So when you working within the same section, proceed from the bottom to the top. And if there is an echogenic change in the passage where the coaxial needle is inserted, it is not possible to confirm the advance of the needle tip. So when looking at the longitudinal view, proceed with the far section first. When the field of view is best, first choose the location where it is difficult to insert the coaxial needle. So if it is in the same section, do the lateral part first and then to the center. If hycoacutic change disturbs the visual field during the operation, you can wait for 10 to 20 minutes. Increased echogenicity disappears within 20 minutes. In the case of small to medium-sized myoma, approximately 6 points need to be ablated. When looking within the same section, proceed from the bottom to the top. When looking at the longitudinal view, proceed with the far section first, and if it is in the same section, to the lateral part first, and then to the center. Next, ablate the top. Finally, ablate the nearest point. In the case of large-sized myoma, maximum 17 points need to be ablated. In the same manner, bottom and far section and top is ablated successively, and then bottom and far section and top is ablated. Finally, ablate the nearest point. When the distance of the previous point and next point is far, the tip must be removed and the coaxial needle must be inserted again. But if the distance is close, the point can be adjusted by just moving the electrode tip. Just slightly retract it and then push it back in with a different angle. This approach helps to reduce the time for coaxial targeting. Myoma burns well with little power. So even if you use the small thermal dose, it is safe and effective to do enough ablation time with the minimal watts to achieve the desired treatment response. Although it is ideal to ablate every corner evenly if possible, if that is not possible, achieving enough thermal dose in each point can still lead to good result. If you put additional energy to the central area after ablation of the whole region, you can make complete ablation without remnant tissue. In the case of small adenomyosis, 5-point ablation should be sufficient, but since it has to be ablated longitudinally, using moving shot or stepping shot, so bottom and far section and bilateral and top area are ablated by stepping shot or moving shot. Electrode tip is inserted into the target farthest side of the layer, and after finishing the ablation, the electrode is drawn back step by step while performing ablation. We call this stepping shot. Adenomyosis has a larger area to ablate than myoma. Therefore, stepping shot or moving shot is often used to reduce the running time. In the case of large adenomyosis, maximum 18 points need to be ablated. In the same manner, bottom and far section and top is ablated successively, and bottom and far section and top is ablated. Finally, ablate the nearest point. In adenomyosis, strong power is required to ablate adenomyosis tissue. So even if you use the same thermal dose, it is effective to use high watt in a short time. Adenomyosis has no capsules, so heat spread around without a barrier. Therefore, it is very important to secure a safety margin. And adenomyosis is often recurring, so you should set a goal to ablate all tissues as much as possible on the premise of securing a safety margin. If you put additional energy by placing EM ablator in the endometrial area after ablation of the whole region, you can improve the treatment result. Next, let's see the RF myolysis treatment video. Okay, insert the speculum and grab the cervix with the tenaculum and secure the passage with sounding. And insert coaxial needle into the target area. After insert the coaxial needle into the target area, check if it is inserted accurately through the transverse scan and the longitudinal scan. And remove the stylet. And insert the electrode tip. And reach the target area and remove the cannula. And then start the ablation. So 6 o'clock, the bottom is first. You should perform the transverse scan throughout the procedure to check that the ablation is being done safely in 3 dimensions. And insert the coaxial needle to the 9 o'clock direction. And check the ultrasound. And remove the stylet. And insert the electrode tip. And remove the cannula. And then start ablation. And next is the 3 o'clock direction. Insert the coaxial needle. And start the ablation. And next at 12 o'clock direction. The effect on symptom improvement such as dysmenorrhea, hypomenorrhea, and AUB is excellent. It has a superior effect than medical treatment, and it gives similar effect to the surgical resection. In comparison to the surgical resection, the satisfaction level for symptom reduction caused by the mass effect is relatively low. So, if the main symptom was caused by the mass effect, RF may not be effective. So among patients who have symptoms such as dysmenorrhea, hypomenorrhea, and AUB, but do not respond to the medical treatment, the patient group without a large mass effect enough to consider hysterectomy should be selected. Postoperative satisfaction is higher in patients with relatively small mass size and severe dysmenorrhea, hypomenorrhea, and AUB. Second, you have to use a sufficient thermal dose for complete ablation. Treatment goal of thermal ablation is complete ablation. If complete necrosis is achieved, the lesion-based reintervention rate is less than 3%. In order to achieve complete ablation, non-perfused volume ratio should be raised. As NPV ratio raised, reintervention rate decreases. So first you see a hyperacute change on the ultrasound by ablating one spot. So the core area has completely ablated by coagulative necrosis and apoptosis, but there are only reversible damage in the peripheral area. So not all areas of hyperacute change on ultrasound are ablated. Therefore, multiple overlapping ablation and sufficient thermal dose is needed for complete ablation. Basically, when the aqua-enhanced area covered 90% of the whole lesion, consider the ablation complete and stop the treatment. Actually, that is what the paper says. But if myoma is surrounded by normal myometrium, I ablate until the capsule turns completely white and then stop the treatment. Intraoperative Doppler monitoring may be helpful. And pre-post CEUS evaluation and post-operative MR or CT evaluation can give additional information. This is CEUS evaluation before and after RF myolysis. There are contrast enhancement in preoperative CEUS, but no residual contrast enhancement within the fibroid in postoperative CEUS. It means that complete ablation is achieved. This is postoperative contrast CT evaluation for myoma, and we can find out that complete ablation is achieved. Finally, let me talk about other considerations. Postoperative management. Patient is hospitalized for a day with using intravenous antibiotics, NSAID, and PCA. The next day, patient is discharged with oral antibiotics and NSAID for 1 week. Postoperative CT or ultrasound evaluation is done a week after surgery. Ultrasound scans are performed 3, 6, 12 months after surgery, and then annual follow-up is done. Next is efficacy of RF myolysis. According to some systemic review and meta-analysis, mean volume reduction rate of the RF myolysis was about 66 to 75% after 12 months. Melody et al. Reviewed 63 clinical papers comparing RF myolysis to uterine artery embolization in volume reduction. Overall, initial uterine volume and fibroid volume tends to be larger in embolization group. The degree of myoma volume reduction is superior after RF myolysis. and the degree of the uterine volume reduction is superior after uterine embolization. And there was no significant difference in the degree of improvement in symptom for each treatment option. RF myolysis is as effective as other treatment and can serve as an alternative to those treatments. Linda et al. And Matthew et al. Reviewed 32 clinical papers for comparison of reintervention rate. The reintervention rate is similar in the myomectomy group and RF myolysis group, while the uterine embolization group is slightly higher. Complications. There are some minor complications like postoperative pain, postoperative vaginal spotting, and vaginal discharge. But all these complications are transient, minor, and non-life-threatening, and easily controlled with medication. Thermal ablation group has a few major adverse events than myomectomy group. RF myolysis in seeking a woman seeking pregnancy. Another modality of the thermal ablation, HIFU, has been approved by the United States FDA as a validated treatment for fibroid in women seeking pregnancy. Therefore, RF myolysis is expected to show similar results. According to systemic review and meta-analysis for comparison of thermal ablative method and myomectomy, there was no significant difference in pregnancy rate between both groups. There is no significant difference in the live birth rate between thermal ablation and myomectomy. On the other hand, the live birth rate after the uterine embolization is significantly low. The rate of vaginal delivery during childbirth is the highest in the thermal ablation. The ratio of the preterm delivery rate and the ratio of the miscarriage rate is similar in the myomectomy group and thermal ablation group, while the uterine embolization group is significantly higher. The stillbirth rate is similar in all three groups. There was no reported uterine ruptures in the thermal ablation group and embolization group, but there was 0.7% in the myomectomy group. But there are two findings to watch out for maintaining the fertility. First, endometrium and myometrium of the subendometrial layer must be preserved. Second, when coaxial needle passes through the internal os, the angle must be deflected to penetrate myometrium and face target area. To damage the endometrium must be minimized. RF myolysis in postmenopausal women. Since the incidence of endometrial cancer and sarcoma is very low, postmenopausal women do not necessarily have to avoid interventional therapy due to the risk of malignancy. However, if one of the four below is present, evaluations such as pelvic MRI or endometrial biopsy are required, and it may be safer to do surgical procedure than interventional therapy. The effect of RF myolysis on symptom improvement for dysmenorrhea, hypermenorrhea, and AUB shows similar result to surgical resection. However, the effect on the mass effect is inevitably lower than that of the surgical resection. Therefore, RF myolysis should be used when the main purpose is the reduction of the above symptom, and reduction of the myoma size should be considered as an additional effect. If the procedure is performed mainly for the purpose of reducing the myoma size, the satisfaction level could be lower than that of surgical resection. In order to increase patient satisfaction after RF myolysis treatment, it is very important to select appropriate patient groups and use sufficient thermal dose for complete ablation. If it is used appropriately for the correct indication, RF myolysis can be a good treatment option for the patient who want to preserve the uterus. And thank you for your attention.